Well, welcome again. We're going to talk about Chapter 15, Cystic Fibrosis and Diseases here. Here's an overview. It's a rare monogenic disorder, mainly affects individuals of Caucasian descent, okay? In Europe, about 1 in every 2 to 3,000 neonates is diagnosed with CF. In the USA, it's reported to be slightly less at 1 in 3,500 births. Okay? And remember that in order to have CF, you have to inherit the defective gene from your parents, and both parents have to have it. So what do we see with these? The airways is the most significant clinical manifestation in the lungs and the airways. In bronchial tissues, the protein is expressed in the submucosal glands and the apical surface of the ciliated epithelial cells. Okay. Most of the time we have really good mucociliary transport. Remember that your body takes care of about 100 mLs every day. Unfortunately, this is not what's going to happen in a patient who has CF. Okay. As you can see with this too, as a result of all the secretions, the patient will have atelectasis. And that's one of the things that we have to work with because the mucus is very thick and sticky, and we have to really work to get it out. So it is the most common fatal inherited disorder in childhood, and you can find it on the chromosome 7. It says there's over 1,700 different mutations. If you look in some of the books, they're going to tell you there's over 2,000 different mutations in this. The life expectancy used to be somewhere in the teen years. Probably about 4 years ago, they came up and said the life expectancy is now about 37 years. So they've made quite a bit of an improvement with the drugs. Remember, too, that the drugs that you see for CF for the most time are orphan drugs because it is a rare disorder also, okay? So those are one of the things that we have to think about. Also, not all of the drugs that come out can be used by all of the patients. They have to target a particular mutation of it. And the latest drug that came out a couple years ago had a lot of promise for the majority of the patients who had CF. So what do we see with this? There's an abnormal transport of sodium and chloride ions across the epithelial cells. This is your bronchial glands, intestines, pancreas, liver, and the sweat glands, okay? And as we said, the mucus is very, very thick, very tenacious, very sticky, and has to be removed. So there's basically 3 broad categories, as you can see. One is affecting the quantity of the protein, another affects the function of it, and then it can either be a gating defect or a conductance defect. And they have a really cool little classification here. If you just look at it, it basically explains it to you. Now, the nice thing in your book also, as you see, they have this picture here, and I like this picture because it basically tells us a lot about what's going on with the genes at that particular point. This is a recessive gene disorder. Both parents have to carry the gene in order for the child to have CF. Basically what it is that you have a 1 in 4 chance every time you're going to have a baby that they could have CF. That doesn't mean that if you have 4 children, only one would have CF. It basically means that each of those children had a 1 in 4 chance of getting CF. Okay? And if you notice, there's a lot of folks who we think have this, but have never been tested for it. And unfortunately, if they marry someone else who has it, who's not been tested, there could be a problem with the children at that particular point. So you have to screen and diagnose these folks. You know, does anybody in the family have this? What are the lab findings if they do? And you have to have two criteria in order to diagnose CF. And one is the clinical symptoms, and then the dysfunction of the CTFTR. So they have different levels that we can measure. There's your elevated sweat chloride greater than 60 milliequivalents per liter on two different occasions. You have your genetic testing, and then there's also the nasal potential difference. People who have CF have nasal polyps, which is something that may be an indicator that you have a problem. Fortunately, now we're doing a lot of screening. All 50 states have started doing it since 2011. And you can see most of the infants that have CF have the elevated blood levels of the immunoreactive trypsin, okay? And they can measure this to see, you know, does this child have it? Most of the time, doctors diagnose most kids with CF by the time they're 3 years old. But if somebody has a milder form of the disease, it may not be diagnosed until that person reaches their teen years. Okay? And babies are usually tested if they're born with an intestinal blockage called meconium ileus. Okay? Because we see that more often in our CF infants. The other things we see with these is frequent lung infections or pneumonia, persistent wheezing, persistent cough with thick mucus, bulky, light-colored, foul-smelling bowel movements or diarrhea, and that happens because the food's not being digested, a failure to gain weight, even though the child eats normal amounts, very sweaty, salty sweat, and if you know, for some reason lick them, you'll find out that they're very, very salty. And they have poor growth charts and nasal polyps, as we said before, along with frequent sinus infections. And these guys also have a lot of fatigue. Okay. So the sweat test or the sweat chloride test, either one is the gold standard for the diagnostic testing of CF. And as you can see, it's a reliable test in 98% of the patients who have CF. So what they're doing is they're measuring the amount of sodium and chloride in that patient's sweat. This is basically how they do it. The test is done twice, and you get 4 times the normal amount of your salty sweat with this. And then in order to follow up, you know, you need to be able to screen these results. And you can see performed after 2 weeks of age, greater than 2 kilos, if they don't have any symptoms. If the infants have symptoms, they can do it a little bit earlier. If someone in the family has the symptoms, they'll go ahead and test also. So these are different interpretations that tell you about whether or not a child has CF. And some of the clinical indicators that justify your initial evaluation, as you can see, we talked a little bit, pulmonary wheezing, coughing, sputum, frequent respiratory infections. How these frequent respiratory infections play into is that we see this a lot of times with patients who have bronchiectasis. And we're going to talk a little bit about bronchiectasis, okay? You'll see some abnormal chest x-rays. There's your nasal polyps again. Digital clubbing because of hypoxia, because of that lack of ability for the gases to exchange because of all of that mucus too. And other things, pancreatic insufficiency. When these guys eat, they have to have a lot of vitamins that they have to take with them. There's prolonged neonatal jaundice. Remember, jaundice is the yellowing caused by the bilirubin. Nutritional defects I'll have. There's your vitamin deficiencies. These are fat-soluble vitamins, so if you don't have the fat, you cannot go ahead and get them into the body, okay? And a lot of the males are infertile, okay? So genetic testing, we can test for the DNA to see if there is this mutation. Then you've got your 2 CFG mutations detected. The sweat test is intermediate or positive, then you do have your diagnosis of CF at that particular point. So the nasal potential difference, this is one that we want to do if we suspect that you have CF. If the test is negative, that's meaning that's more increased, then it strongly suggests this person does have CF. And then you can look around and see what other features that we see. Prenatal testing, they do offer screening for CF mutations. And then, you can see if the father's not been tested, we can offer that to them. If they both test positive for it, and there it is, your baby has a 1 in 4 chance of having it. They can do an amniocentesis on the fetus after the first trimester, and it can basically say, do you have it, are you a carrier, or you're normal? And just remember that normal does not mean normal. And once you find out, genetic counseling is really important. Not only that, this is something you have to pass on to your children. And you can say, well, the child has it, then they know they have it. And that's very, very true. But the other children of the marriage, too, need to know that they could be carriers and they do need to have genetic testing. They're going to get married and have children. And then you can do a stool fecal fat test. Okay, this evaluates your liver, gallbladder, pancreas, intestines. So if you notice too, there's a fetal elastance of less than 50 micrograms per gram of stool, where the normal is 300. The worst organ affected, of course, is always going to be your lungs in this case. We see atelectasis, bronchospasm, excessive bronchial secretions, and then we talked about the fact that you can go ahead and end up with bronchiectasis at that point. The other thing you can end up with is pulmonary hypertension. If you also get pulmonary hypertension, you can end up with cor pulmonale, which is your right heart failure, okay? And we also see a lot of edema in the legs and the ankles because of the fluid retention, okay? And so you really got to watch what's going on with these patients. Vital signs, typical vital signs we see with our obstructive diseases. There are the increased respiratory rate, heart rate, your increased blood pressure, accessory muscles, your inspiration, expiration. Remember, when you're exhaling, it's always supposed to be passive. If you're having to work at exhalation, that means that you have something wrong, and we need to know what it is. And these guys teach themselves pursed lip breathing. Sometimes we'll teach it with them too also. Just remind them that this is something to use when you're having problems breathing. They could have barrel chest, however, it could be reversible somewhat if we're going to get the airways cleared. Cyanosis, we talked about that, digital cloving, and they do have cough, sputum, and hemoptysis too. And so just like with your other obstructive, decreased tactile vocal fremitus, hyperresonant, all that ear trapping that's going on. However, you're going to have diminished breath sounds for the most part, but if you have any areas of atelectasis, remember early on we said you do have atelectasis with CF, then you're going to have the bronchial breath sounds at that particular point. You're also going to have crackles and wheezing, and there you can see a spontaneous pneumothorax, 20% chance in adults and 50%. What means it'll come back. PFT is basically the same with the APGs. So some abnormal lab test, you're going to see an increased hematocrit and hemoglobin. Goes right along with your hypoxia, an increased white blood cell because of all the infections these folks have. We're going to see that. The electrolytes are going to be off a bit, but you're going to see the hypochloremia, and then an increased sodium serum bicarb when you have chronic ventilatory failure. In the sputum, with looking for what are you carrying. A lot of gram-positive ones are the staphylococcus and the hemoptysis. Gram-negative, Pseudomonas. Pseudomonas seems to be the major one we have with this. Remember that these patients have to come in and have tobramycin in order to take care of that Pseudomonas for them. Another one we have to watch for is Aspergillus. You'll see Aspergillus sometimes with asthma, but you can also see with your patients who have CF. Chest radiograph, basically the same, very dark, flattened diaphragms, right ventricular enlargement. You see the atelectasis, fibrosis, tram tracts, and their bronchiectasis, and all of those other things that go with it too. And then on occasions you get abscess formation that contributes sometimes to that really foul-smelling sputum. And when we talk about bronchiectasis, we can also have abscesses, which contributes to that also. So this just shows you some of the what the x-rays could look like. There's your lung collapse and the right upper lobe collapse. There's a ring shadow with a thick arrow. A double arrow is compensatory hyperinflation at that point. And basically, distal intestinal obstruction syndrome basically is a blockage of the intestines by thickened stool. It's similar to constipation in that the stool is backed up into the digestive tract. However, it's much, much higher in the intestines than it is as if you're constipated. And then malnutrition, poor body development because of the vitamins that you're not getting or unable to absorb. There's your nasal polyps, sinusitis, and infertility for the males. So what are we trying to do? Try to prevent those infections, reduce the secretions. You have to drink, you have to do other stuff to make sure that you can take care of yourself, improve your airflow, and provide adequate nutrition. And the patient's family has to be involved with this. It's interesting, at one time, one of the case studies that the students had done was that there were twins, and both of the twins had CF, and one of the twins took very good care of herself. The other twin didn't. She was in really, really bad shape. You get to the point sometimes when these kids are teenagers that they're going to do what they think they have to do. If they leave home and go to college, they're going to do what they think they want to do and become part of the college life. And sometimes that causes major issues for them down the road. So things we do, oxygen therapy, airway clearance, we'll talk about those, lung expansion, a lot of what we call our PEP devices, positive expiratory pressure devices, were designed for the CF community, and we have just moved them over and used them with our other patients. You have your bronchodilators, mucolytics, remember DNase or pomazine is the one we want to use with this, hypertonic saline, mucomist, not really. And if we need to, we have to put these folks on mechanical vent to help them. And then you have your correctors, your potentiators that are going to help you with those too. And then things, antibiotics, ibuprofen, corticosteroids. And then perhaps longer heart-lung transplantation. Now, one of the things you need to know if you're taking care of patients who have CF, you have to be a strong therapist. And what I'm talking about with this is if you go into the room and go, hi, my name is Louise, I'm with respiratory, here, what's your treatment? Most of these folks will look at you like you've lost your mind and tell you to get out. You need to go in there and basically tell them it's time for your treatment. We need to be able to do this. You haven't had it for the last X number of hours. You're in the hospital for your clean out session. They'll do that on occasions. And you need to have these treatments. When you're doing postural drainage and percussion, which they like chest physiotherapy, we don't do as much as we used to. We have the vest and other things to help with it. But when you're doing that, if you're just sitting there just barely touching them, I don't want to hurt you, I'm sorry, they're going to tell you to leave. You are part of their lifeline, and you as a therapist need to know that. Remember that you have to work with them, and you have to convince them that you're very interested in what they're doing, and make sure that they're going to be able to do the things that they need to do.